Hello, good evening. Welcome to My Advances and the European Fertility Society. We are back once again with Dr. Elias Tsakos. You can see him right here, of course, with us. Hello, Dr. Tsakos. I'm happy to have you back with this particular topic as well. We've done it before. We talked about PRP and different aspects, and I know that this is a topic that is let's face it, it's really popular nowadays as well. I can see of the numbers, of course, the people that are joining us today as well already. So thanks a lot, everyone, for joining. And how have you been? Great to have you here.
Fabulous. Nice to see you, Caroline, and thank you for organizing this. And I have some exciting news to share with you, both from the international literature, but also from our own experience at Embryoclinic.
That's great to hear. That's great to hear. That's why we are here. Of course, we will talk about PRP and whether it can improve endometrial receptivity for better IVF results. This is our topic today. Very exciting. I already seen the presentation, so I know a little bit what is going to be discussed today. So I'm sure it's going to be an interesting session for you. Before we start with the presentation on our topic, let me remind everyone that Dr. Elias Tsakos is the medical director at Embryoclinic in Greece, Thessaloniki. So we have 1 hour for around 30 minutes for the presentation, but afterwards, Dr. Tsakos will answer your questions. So as always, please put those in the chat. I'm sure Dr. Tsakos, as always, will be happy to help you out with any tips, anything that can be, of course, useful and helpful for you. It's being recorded as well, and I think now we can go ahead with our presentation. And you can type the questions during the presentation or afterwards, and we will definitely take care of those. And yeah, let's go for it. Okay.
Brilliant. Thank you very much. I will
Thank you
try
so
to
much
keep
indeed.
it short and sweet. Basically, this is a subject that I've been avoiding to discuss, and I've been avoiding to utilize for many years, for nearly 10 years. My team and I have been studying all the research, all the evidence. We've been interviewing certain experts in the world about this technique, and it took us about 10 years of studying, reflection, and protocol creation in order to start offering this to our patients. The kickoff for this new service at Embryoclinic has been a very nice meta-analysis, review and meta-analysis that was published at the end of 2023, which I will analyze, and also the fact that ESHRE, the European Society of Human Reproduction, has embraced this procedure by offering a masterclass in a workshop during the last year's annual congress. So that was the kickoff for us, for our experience. Now, IVF has been traditionally focusing on the lab, on the laboratory, on the eggs, on the sperm, not so much on the sperm, and this is another topic that I would like to introduce you to for the next few years, the next few lectures and webinars. And traditionally, the IVF, if you like, scientists and doctors and industry have neglected a very important factor, which is the endometrium, which is the implantation, which is the human incubator, which is the amazing organ, female organ of the uterus that has the ability to sustain a pregnancy for 9 months. And I'm very curious to have discovered that one of the reasons why this has happened is the fact that our specialty has shifted over the last decades, in the sense that although initially we were all trained to be endoscopic surgeons as well as IVF specialists, now it's moving more towards IVF and more towards, from the clinical aspect, reproductive endocrinology and infertility, and less in terms of clinical and surgical aspect of infertility. And I would like to say that in the last 10, 15 years, there's been a division in the specialties. So the IVF specialist was also a specialist in endoscopic surgery is becoming probably a thing of the past. And now we're seeing emerging two different specialties, which is one is the IVF doctors, focusing on reproductive endocrinology and infertility, and a different set of doctors who are focusing on endoscopic surgery. In my team, we're fortunate simply because we're a big team. We have 7 gynecologists on my team, so we're fortunate to have been able to sustain, not only to sustain the skills of endoscopic surgery, but also to extend those and to become part of the future, which is the combination of the skills, of the surgical skills, and also the laboratory skills. So what is the connection with PRP? There's a huge connection there, because it reminds us of the importance of the uterus and the endometrium. It reminds us of the importance to look into the endometrium more closely, both in terms of diagnosis by means of specialized ultrasound scans, 3D and 4D ultrasound scans, which is another skill, which is another technology, which thankfully has helped us a lot in identifying areas of the endometrium which need to be looked at, and of course to reevaluate the importance of a hysteroscopy and of evaluation of the endometrium. So many times I receive every day, I receive requests from patients stating simply, I've had so many failures with very good quality embryos, and not a mention about the endometrium. With regards to examining the embryo, we've gone so far with artificial intelligence, with time-lapse monitoring, with PGTA testing, and all that. But we have neglected over the last few decades the importance of the endometrium. So I'm very happy that now that we seem to have unsolved, or at least answered most of the issues regarding embryo quality, that we're coming back on ourselves and looking into the implantation factors. And this is where the endometrium comes in. And of course, by doing those tests, by specialized ultrasound scans, by hysteroscopies, by biopsies on the endometrium, trying to identify other factors apart from a standard histology, we can identify within the same biopsy the chance of endometritis, the possibility of endometritis, which I mentioned in a previous webinar, by simply checking another marker, the CD138 plasma cells marker on the biopsy. We can check the microbiome of the endometrium. We can do PCR testing for microbes in the endometrium as well. And finally, we can check for NK cells. So the endometrium has acquired, its place, if you like, its importance in sustaining and in sustaining the good quality embryos that we're creating, and in making those embryos into a healthy baby. So quite a long introduction, but I just wanted to get something straight. So, my talk is 33 slides. 3 or 4 of them are literature, so not too long. So it will include an introduction to the endometrial PRP, how the PRP is produced, how does it work, what is the mechanism, what is the science behind it, what is the scientific evidence, is there evidence, and what is that evidence, and what are the future prospects. So pretty straightforward. So introduction, what is it? It's an autologous product. Most of our patients are familiar with that. Most of the doctors are familiar, very few dig deep. So I just hope that after this webinar, you will have a lot of data to look back into, and hopefully to decide if it fits your case or not. So it's peripheral blood. We prepare this via centrifusion, which is a very standard, or perhaps not so standard, because I will try to explain the protocol, and I will try to explain that most units have their own protocol, but I will pinpoint some areas that need to be carefully looked at. Usually there's no extra medications or substances added, although there is emerging evidence that we may enrich that platelet-rich plasma by inserting and by including other substances Exosomes are becoming more and more popular. Hopefully next year I would have some more data on that, and it seems that to be very promising. Exosomes and also stem cells. There's a lot of research on stem cells, plus other possible growth factors that may may increase the effect of the PRP treatment. But at the moment, for the purpose of this talk, I will just talk about the standard PRP. It's a very simple delivery into the patient via infusion, although we can perform focal insertion of PRP into focal areas through hysteroscopy as a second line, and I will elaborate a little bit more on that. It's a fairly safe procedure. Here it says low incidence. I would say minimal incidence of possible allergies and adverse effects. And, the vast majority are absolutely self-limiting without the need for any extra care. And the PRP treatment has been used for many years, for more than 10, 15 years, in many specialties, such as aesthetic medicine, on the face, on the body. The orthopedic surgeons use it quite a lot, especially into athletes or into patients that need to recover fairly swiftly and so forth. And recently, aesthetic gynecology for vaginal rejuvenation and vaginal improvement, especially in women in the perimenopause or menopause years. And of course, reproductive medicine. And reproductive medicine has been used fairly widely in the last 10, 15 years, even before the evidence emerged. So how is it done? Very simple and quick, straightforward. The little catheter, we go into the uterus. To be honest, I didn't draw this picture. If I did, I would probably put this catheter up to here, not as far as here. But never mind. So little catheter, just like an IUI or like an embryo transfer, and we just we bathe the endometrium into the PRP fluid, and the whole procedure takes 8 to 10 minutes. How is it produced? Now, this is one of the tricks that most of the clinics are keeping fairly to themselves. We're hoping to be able to publish our results within the next 18 months, and then we will reveal our protocol. But in essence, because we're very curious to see the effects. We're measuring different factors as an effect in terms of both the effect on the visual effect on the endometrium and the various parameters on the endometrium assessment via 3D and 4D scan, and also, of course, the outcome with regards to fertility, implantation, ongoing pregnancy, miscarriage, and live birth. So with no blood from the patient, this is the whole blood, and then the blood goes into centrifusion. There's a lot of tricks of the trade here. The time of centrifusion, the type of tubes we use, the revs per minute of the machine, and how many times we do it, and so forth. The aim of this procedure is to produce the end product, which would be approximately 1.5 to 2 mL, that would be totally red cell free, and that would be definitely very, very rich on platelet concentration, One of the limitations of the studies, and one of the reasons why that it hasn't been widely adopted or accepted as a technique scientifically at the moment, is that most people in the research and the publications, they do not include the protocol, how many mLs of blood do we draw, and B, they don't measure, they don't do what we have established as quality control, which means that we measure every single time, we measure the concentration of platelets that we inject to our patients. And we aim to have a minimum concentration of 800,000 platelets per ml and less than 1.5 million. We have tried not on our patients, but we have done quality control on many of the commercially available kits of producing PRP. And sadly, we found that the maximum concentration of platelets we could reach was about 400,000, which according to the science is inadequate. So if I were to provide a take-home message here, is that if you are having PRP treatment in any facility in the world, I can see amazing people from everywhere, the US, I can see people from Europe, I can see some of my team. Thank you guys for staying up all night for me. I can see patients and people and friends from England, hi guys, Australia and so forth, and France, amongst other countries. So there's a lot of people here. There's one Spanish person as well, and I hope it's going well with the blackout in Spain. Anyway, if you are to take one take-home message, ask your clinic to give you feedback, to give you measurements of the concentration that they've achieved. And this is just a very standard sheet of record and report on the concentration and the volume that was injected. And also, of course, it's very important to perform, because platelet and blood and plasma are wonderful feeding grounds for microbes to grow. So part of our procedure here is to measure and ensure that this is totally aseptic, in order to decide if we need antibiotics and so forth. So these are the two measures that I would encourage everyone to perform. And also by doing those, hopefully we can combine some data from various units using various protocols, but at least achieving a microbe-free sample containing between 800,000 and 1.5 million platelets per ml, which is blood-free. So how does it work? I mean, what does it do, that platelet concentrate? What does it do? So there's a lot of mechanisms, which I will try to explain shortly. I call it humble platelet because there's thousands of those in our bloodstream, and it's a very humble cell. It's not celebrated, not as much as, for example, the red cells. As you probably know, we carry about 37 trillion cells in our body, and about 30 trillion are the red cells, and they carry the oxygen and they do all sorts of wonderful jobs. So the platelets are pretty humble cells, but they have a lot of power, especially if they're properly concentrated and delivered. And these are the useful proteins they contain. Peptides, growth factors, anti-inflammatory factors, so everything your uterus, your endometrium, and your embryo needs in order to grow in a healthy environment. And the mechanisms are through cell proliferation, tissue healing. This is particularly helpful in women with Asherman syndrome, and we're very proud to report that we have amazingly good results in Asherman syndrome in very difficult cases, very difficult patients. Arriving from all over the world. And of course, there's neoangiogenesis and there's immune modulation. So all sorts of wonderful mechanisms which would facilitate the endometrium to become as optimal as possible. So cell proliferation, I'm not going to go into a lot of detail, but both the epithelial and stromal cells can grow, and they become better and they become thicker. Now, here's a word of caution. I mean, don't expect miracles, in terms of thickness. And thickness is only one of the 5 important parameters, if you like, of measuring the endometrial capacity. And you may only find 1 millimeter or 2 millimeters increase in thickness, but all the other parameters, the vasculature, the Doppler studies, the shape, will be improved. So it's not just, most people believe that it's only the thin or thick endometrium, but there's a lot of other factors in the endometrium which may not be visible even with a high resolution scan, affected by PRP. So proliferation of mesenchymal cells, and of course formation of new vessels, new vasculature. Immune modulation via the cytokines and the interleukins also may help and may assist. And again, this may be even more relevant in women with recurrent implantation failure or women with miscarriages that need this little bit of extra help, or even patients with history of endometritis. Also, take-home message here is that there's a lot of ways to check your endometrium, apart from just doing a visual hysteroscopy. This is the standard biopsy. This is the plasma cell. Look for plasma cells on the biopsy tissue. Look for the microbiome, proper microbiome testing, microbiota testing on the endometrium. If you want, you can couple that by PCR testing for microbes, and finally for natural killer testing. So there's a lot of questions we haven't answered for most of our patients. And of course, this is not relevant to the standard, straightforward infertility patient, but it becomes more and more relevant as we move towards difficult cases, recurrent implantation failure, recurrent miscarriages, patients with Asherman syndrome, with pelvic infection, and so forth. And of course, the reduction of scarring is through, this is very helpful. And, in our series, we have amazing results. Actually, I didn't include this in my slides, but we have amazing case studies of patients with complete Ashermans referred by amazing doctors, colleagues of mine from all over the world. And, every time I get a referral from a fantastic doctor, I always don't sleep the night before, because I'm always worrying whether I can offer something to my patients or not. So we have some amazing results with a combination of PRP, complete Ashermans, complete obliteration of the cavity. We pre-treated with PRP, and then we went back 6 weeks later. We did a diagnostic hysteroscopy. We did a moderate adhesiolysis, another PRP. 6 weeks later, another hysteroscopy, further PRP, and then we produced a wonderful endometrium that even ourselves we couldn't believe sometimes. So this is the extra bit of help that the endometrial tissue may require in order to heal, itself, if you like. And of course, that not only does it promote tissue remodeling, but also it prevents further adhesion formation. So what is the evidence? I will only cite, there's a lot of case reports, there's a lot of small series. Most of them are not standardized. Most of them, they don't really produce robust evidence. And that was one of the reasons why my team and I were hesitant. It took us, as I said, 10 years to start using PRP. We're very happy with the results. And one of the studies that we based our protocols on and made us kickstart and kick off was this meta-analysis of 2023, which included good quality studies and showed about 80% better implantation rate, more than 8% clinical pregnancy rate, and lower miscarriage rate. So very, very encouraging results. And of course, that concluded with about 75% live birth rate. Here, we're talking about the average infertility patient. Now, that scientific team, they looked into the thickness, and they confirmed what we have also confirmed. I think it's very important, and I'm calling out for colleagues all over the world. If you're hesitant about using those, I'm more than happy to share our protocols. I'm more than happy to share, how we produce our PRP, how we standardize patients, how we select, how we inform and consent our patients. I'm more than happy to collaborate in order to control all the factors that can be controlled in order to produce a high impact scientific paper, which I'm pretty hopeful that it will confirm the beneficial results. The more of us get together, the better for the benefit of our patients. And I offer our scientific and research team here at Embryoclinic, totally complementary. There's no, part of our mission here at Embryoclinic is to produce good quality research for the benefit of our patients. So if you want to collaborate, just get in touch with us. We fund ourselves, so we don't look out for funding anywhere, but we can assure you we can produce good quality evidence if we combine our forces. And in those average infertile patients, there was more than 70% positive beta HCG with no difference in multiple pregnancy or ectopic rates. So that was fairly reassuring. Now, patients with recurrent implantation failure, similarly, more than 80% clinical pregnancy rate, half miscarriage rate, and more than 8% take-home baby rates, which is very important. They lower miscarriage rate in patients with thin endometrium. So, take-home message: the endometrium may still be thin, but the function of the endometrium will be, it seems to be getting much better. Now, what are the future prospects of HRT, of PRP? I'm working on another project at the moment for perimenopausal women. Actually, there's a lot of interest into that group of patients, and I would be more than happy to share experience and data perhaps next time. So there's another way of inserting PRP, which is through, it's a little bit more invasive. It's through hysteroscopy, and we do subendothelial injection through a needle of the PRP subendometrially. This is more appropriate in more difficult cases or in cases with localized lesions. You have the occasional patient who's had a miscarriage, a DNC, or some adhesions localized, sometimes after a myoma resection by hysteroscopy or a polyp resection where we went a little bit more enthusiastically deep into the endometrium. They have a localized area of adhesion. So in that case, a hysteroscopic PRP may be more appropriate. And I have to say that unless the 3D, 4D scan, and much to my dismay, most IVF patients, most fertility patients, they haven't had this luxury of having had a 3D or 4D scan. So unless, and I urge them to proceed and have this one. Not only will it diagnose endometrium better, but also it will diagnose any potential issues on the myometrium, any potential adenomyosis, myomas, and also it can exclude with good accuracy the possible presence of endometriosis. So I would urge patients to, unless they have a perfectly normal 3D or 4D scan, not just the standard 2D scan. In our experience, about 30% of our patients who were deemed to have normal vaginal scan findings on the vagina, on the standard 2D vaginal scans, we revealed some sort of anomalies on the 3D, 4D scan. So I would urge the patients to undergo this technological assessment. And so I was saying that unless someone has a perfect 3D, 4D scan, I would suggest that the hysteroscopy is the gold standard in assessing the endometrium, and not just a visual hysteroscopy, but also coupled with some tissue biopsy, as I explained. Now, what about other areas apart from endometrium? And we have the ovaries. This is outside the scope of this webinar today. But I have to say that I'm very privileged to have been given the opportunity to talk about this in September. There are some promising evidence. The evidence is not as clear, to my opinion, as it is for the endometrium, perhaps because what we wish to achieve on the ovaries is a little bit more complex. Not only do we want to improve the modulation, the immune modulation, not only do we want to improve the neoangiogenesis, but there's a limiting factor of the quality of the eggs, which may not be affected, the number of primordial follicles. PRP is not going to grow new follicles if they're not there, but perhaps it may enhance the response of the existing follicles to hormones and so forth. So it's a little bit more complex. At the moment, my general feeling, if I was to give you my opinion, is that perhaps is not as effective on the ovaries as it is on the endometrium, and also that we need to select our patients very carefully. If it is to be effective, it may be effective more in younger patients and not in the patients, for example, beyond 45. Having said that, I think we still need to gather evidence. I still invite my colleagues and friends all over the world to combine their data, perhaps to develop a protocol to study some patients prospectively, perhaps to do. It's not that difficult anymore to set up a randomized control trial in order to see if there's really some benefit or not. But in either case, I'll keep you posted in September about this. So take-home message: PRP is autologous. Autologous is a fancy Greek word for it's our own stuff. It's made by our own self fluids. It's a blood product that has been safely used and successfully in many medical fields. Largest example is orthopedics, especially competitive sports orthopedics, and also aesthetic medicine. And now it's becoming more and more popular in fertility. The PRP induces cell proliferation and improves vascularization and blood flow in the endometrium. It's a simple, painless, quick, and safe procedure. And the reproductive outcomes, based on the studies that I presented, have been fairly impressive, especially in women with recurrent implantation failures, especially with good quality embryos, and with patients with a history of thin endometrium associated with previous surgery or adhesions. This is the literature. Feel free to take some snapshots of that. Fairly good literature and very recent. And this is my team, to which I'm very thankful for holding the fort while I'm studying all new avenues of improving the benefits and the experience of my patients. Thank you very much, and I'm very happy to take questions.
So for our questions, there are plenty of those. So let me just go to the first that we've received from Karen, who had been in our sessions before. So thin lining, short periods. I had NK cell test and hysteroscopy before, not found any reason, but going to repeat both these from questions in the past to Dr. Tsakos webinars, which sounded beneficial. Also doing now a fertilizis testing panel to try and find reason, also to rule out endometritis. Currently use Viagra pessaries to help. Could PRP help, or any other advice? I'm 40, so not got time on my side. Or also 4 IVFs all were negative.
Sure. Thank you, Karen. I mean, first of all, I would only have IVF. I would suggest only have your embryos PGTA tested. So in my opinion, this is imperative in your situation in order to ensure that you have DNA competent embryos. There's no point, after so many failures, after all this effort, to go ahead with embryo transfers with embryos that are not PGTA tested. Now, PGTA testing does not mean that you will get pregnant, does not mean that you will have an implantation. What it means, however, is that if we optimize your endometrium, you may have the chance of success of a 34-year-old, which is remarkable. So if you have IVF, let's isolate 2 factors, what I mentioned in my introduction, my pretty long introduction: embryo, endometrium. Those 2 factors probably together combined is 90% of the success of the equation. So optimize your embryos by having PGTA testing. Put them onto the side. So you have 1 or 2 good quality embryos. So you are 34. You have the chance of 34. And then focus on the endometrium. On the endometrium, I will do hysteroscopy by an experienced hysteroscopist. What I see normal may not be normal of my colleague who started last year with me. It takes, I get on my team very experienced doctors, most of them with amazing studies, but it takes about 2 years for us to line up visuals, if you see what I mean. So hysteroscopy, what we see is not, objective. Some people see a big mountain, some others see a small mountain. Equally with the hysteroscopy image, and also remember that hysteroscopy is 2D, 2-dimension, and this is a call out for the technology industry. We have 3D laparoscopy, 3D robotics. Give us 3D, give us equipment to do 3D hysteroscopy. Why are we left in 2D? And I will tell you why. Because there's not a lot of research on hysteroscopy. And this is our fault. We haven't shouted loud enough how important it is. All right? So it's 2D. What I see, my eyes are trained after 30 years. I see 2D, I convert it to 3D. That's why I don't use 3D laparoscopy. I use 2D because my brain has remodeled and I see 3D even on 2D. Of course, when I do a robot, I'm more, because it's 3D, I'm more relaxed and I'm more, I don't consume so much energy. But that's not always the case. So hysteroscopy by itself is not accurate unless you do those 5 tests. Take a sample for histology, take a sample for CD138 plasma cells. We do this combined. We don't even mention to our patients, no extra charge, nothing, because I think it's amazingly important. If I were to do, I'd rather do just the CD138, not the standard biopsy, but we do both. So it's, it's not negotiable in our department. Just like IVF and ICSI. At Embryoclinic, you don't pay for ICSI. It's part of IVF. If we think it's ICSI, we're not going to call you up and say, oh, hi, can we have another 1,000 for doing ICSI? Whatever we do in the lab, it is our responsibility to give you the best possible outcome, and equally with hysteroscopy and biopsy. So biopsy, CD138, NK cells, microbiome, latest generation of NGS microbiome, and I would do, in your case, PCR testing for microbes. That's that.
All right.
Yeah.
Thank you so much indeed.
Even if it's very unlikely that everything will come up normal. If I were to predict, because you've done a lot of good tests, a lot of good work, I would predict that probably your microbiome is off the range. And that can be simply treated with lactobacilli. Very simple. If you were not to do that, I think it's very cost effective. To be honest, more and more I do it blindly, routinely on my patients without testing, to avoid all the, for the easy cases. I invariably give them lactobacilli anyway. It doesn't harm. It's good for your gut. It's good for your uterus. It's good for your brain. I take it myself. So yeah, sort out the embryo problem and then sort out the endometrial problem, and you will get pregnant, I'm sure.
All right. Thank you so much indeed for this. And of course, if you have any other follow-ups, go ahead. Okay, I will show the next question from Chiara, as there are some questions in one here as well. So is there a link between thyroid antibodies and thin endometrium, thin lining, recurrent implantation failure, stage 4 endometriosis, high NK cells, treating microbiome at the minute? Got PRP for last transfer, resulted in a chemical pregnancy. Nutritionist mentioned there may be a link between thyroid and thin lining. My thyroid is normal, but thyroid antibodies are a little elevated. Anything you can advise here?
Sure. Thank you, Chiara. Basically, I think it's very difficult to answer that, but all I have to say is that you have a lot of reasons. You have a lot of enemies, if you like, to fight in order to achieve a pregnancy. In my opinion, I think you should fight them separately. Now, let's start with, it doesn't really matter if it is linked or not. What it matters is that Hashimoto, thyroid disease, Hashimoto, is by itself, maybe by itself, an enemy, one big enemy. Thin endometrium is by itself, so look into them on their own merit. So Hashimoto, one enemy, thin endometrium, endometriosis. Sorry, I've lost the. You took it off.
Sorry, yeah, I will show it to you. No worries, of course. Just give me a second. Oh, sorry, this is not it. There are many questions, so just give me a second. I will find the right one. That was from Chiara.
Όλα καλά. Σε webinar, αγάπη μου, σε μισή ώρα είμαι σπίτι. Bye. Family calling. Sorry, I have the French
Yes, I'm trying to find it,
The
and
one
it's
before that.
right here.
Oh, yeah,
Apologies.
I got it. Thyroid, thin endometrium, implantation failure, stage 4 endo, high NK cells microbiome. Yeah, look into them one at a time and then all of them together. Now, I will give you some piece of information on Hashimoto. Hashimoto is very common, very common. 10-15% of women have Hashimoto. Look into this very carefully. Google it, ChatGPT it, become an expert in Hashimoto. Question number one: most people don't supplement with thyroid if TSH is normal with Hashimoto. I disagree. I think you definitely need supplementation. Number two, even if your TSH is normal, even if your T3, T4 is normal. So I don't know whether you're having supplementation. So definitely have supplementation if you're undergoing IVF. Number two, look into micronutrients. We are failing our patients by just checking TSH. That's not enough. We need to do the full panel, 5 hormones, and also we need to check for vitamins and micronutrients. And invariably, those are deficient. Look into supplementing. I mean, Hashimoto needs vitamin supplementation, either through food or through supplements. So look into the Hashimoto. And also look into other autoimmune conditions that you may not be familiar with. One autoimmune disease may be associated with another autoimmune disease, which may not be diagnosed. Now, stage 4 endo, I hope it's been operated on, and I hope it's been operated on properly. But if it has, fine, very happy. If not, it needs to be tackled. I mean, again, the dispute between IVF doctors, reproductive endocrinology and infertility specialists, and endoscopic surgeons. Who is right, who is wrong? Nobody's right and nobody's wrong. They need to get together. Endometriosis, I've been to the most amazing centers in the world, but there are very few. And how can you understand if an endometriosis center is top notch, if they have a fertility specialist in the multidisciplinary team or not? Unless we have to be included. It's not just the surgeon, it's not just the endometrial surgeon and reproductive endocrinologist. So look into the endometriosis. If you had stage 4 endometriosis, there's a good chance that you may have adenomyosis without knowing. So look into this. Have a high resolution 3D, 4D scan. Make sure you exclude adenomyosis. And if you have adenomyosis, discuss the options to tackle it. Pharmaceutical, lifestyle, supplements, and so forth. Treat your microbiome, treat your high NK cells. And now PRP, sometimes we need to do more than one PRPs. That's another little secret, depending on what we're treating. In my opinion, if you've standardized everything else, and if you have a reasonable endometrium on the 3D, 4D scan, then perhaps one is enough. But to be on the safe side, what I do is that on the first embryo transfer cycle, or whether it's natural or whether it's medicated, I usually, in your case, I have my precious normal tested embryos on the side. I do PRP once, possibly day 8, day 9 of estrogen treatment, and then I evaluate again on day 14, 15 prior to embryo transfer. If I'm happy with the endometrium, I leave it be. If I'm not happy, I do a second PRP. I hope I have helped.
All right. Thank you so much indeed. Lots of details. Once again, thanks a lot. More questions are coming in. I will show you this question. Do you believe PRP can also be used apart from IVF after a dilation or curettage in order to diminish the possibility of adhesions in clinical practice? Anything you can
Thank you
answer?
so much, Elias. Thank you. Very nice to see you here on the webinar. That's a very good clinical question. It depends, is my answer. Depends. Firstly, I would say that in my practice, I never do dilatation and curettage, ever. Never, ever. This is one of the no-nos. I haven't done a dilatation and curettage without a hysteroscopy in my life. And I've been around for about 35 years. So I do a hysteroscopy. I presume you're referring to dilatation and curettage after a miscarriage. And I will share a little bit of my secrets. I think we have a very loyal and amazing team watching us. I can see about 30 people here, which is, again, a little trick of our trade here at Embryoclinic. We don't do blind DNC for miscarriages anymore. We've stopped doing that. What do? We do hysteroscopic removal of retained products of conception. Why do we do it? Because we kill 4 birds with 1 stone. Firstly, DNC, Stelios and my dear friends on the webinar attendees, DNC was the last, and I hope it will always be the last, blind technique of medicine, of the entire medicine, not just gynecology. Why did we move on to hysteroscopies to remove polyps and fibroids and hyperplasias from the endometrium? We moved into hysteroscopy possibly 25, 30 years ago, and we're still doing blind DNCs for retained products of conception for the most valuable population we can ever have, the fertile population wishing to become mothers. So hysteroscopic removal of retained products of conception. Why? Firstly, we see the sac, we see the products, we see the retained areas, and we go focally to remove it. Invariably, it's in one of those quads of the cavity, unless it's a very advanced pregnancy beyond 10 or 11 weeks. But in that case, we would consider providing medical treatment for expulsion of the embryo anyway. So why scrape the whole uterus? Why risk the whole uterus for adhesions, infection, damage, bleeding, if you can only focus on one area which has the retained products? So firstly, we go localized. Secondly, we remove it completely. We've all had it. I've had it. Everybody has had it who's done, a few hundreds, a few thousands, retained products of conception. When you do the blind DNC, you have 2 risks. One is you leave some behind, and the other is that you take away healthy endometrium. So we avoid that. Yeah. Number 3, we have 100%. We have diagnosis. How many times have we had a patient with a miscarriage, and we said, okay, you had a miscarriage, we had natural miscarriage, after IVF miscarriage, whatever. Oh, let's do a hysteroscopy to make sure you don't have myomas, polyps, you don't have any heart-shaped uterus, diaphragms. How many times? Almost 50%, 70% of the time. So the woman has had a dangerous procedure, blind procedure, which is the DNC, and then they've had a second procedure, which is a hysteroscopy. And that repeat dilatation may cause a problem. So that's number 3. So at the same time, we present all the evidence that we have a normal uterus, or we have a uterus with adhesions, or we have a uterus which is heart-shaped, or even with diaphragm. We diagnose that. And number 4, we can use the instruments with less dilatation of the cervix. So the cervix does not get fully dilated, so we can have a smaller dilatation. So coming back to your question, would I do PRP or not? Depends is the answer. If the uterus is normal, because I visualize, it's not just a blind DNC, I see. If I see adhesions, if I see some areas that may require a little bit of extra help, I can consider that. I can do it in one time during the procedure, but invariably I like to do it at the second stage, having discussed and counseled the patient correctly based on the findings of the hysteroscopy, and do it a little bit later.
Right. Thank you so much. Definitely interesting. This question, of course. Thanks a lot for explaining. I will show you the next questions. Question from another patient here. Besides recurrent implantation failure, Asherman's, and the other problems cases you mentioned, would you ever recommend doing endometrial PRP prophylactically if pregnancy has not been achieved after multiple transfers of untested embryos?
Sure. Yes, I would, is the answer. Is the answer?
Mhm.
Yes, I would. I would. And it wouldn't be prophylactically. I mean, prophylactically would be if I did it on the first embryo transfer. No, I wouldn't do it on the first embryo transfer unless there's clinical indication. But recurrent implantation failures, or even two implantation failures or more, would be an indication to consider PRP. But as I said to our previous attendee, I would always look into the embryo as well. You know, you can't fix one and have the other one untested or unfixed. Now, whether I do a PGTA or not, again, depends on the age, depends on the number of miscarriages. For example, if I have a 32, 33-year-old, 35-year-old with one or two failures, perhaps PGTA is not 100% indicated. You know, this is a gray area. But I would like to do it. I mean, look, in my opinion, the biggest risk of failure of IVF, the biggest risk, bigger than ovarian hyperstimulation, bigger than ectopic, bigger than miscarriage, bigger than complication of the miscarriage, complication of pregnancy, is giving up. That's the biggest risk, is having a wonderful woman or a wonderful couple who are just going to give up. And they will give up if we don't give them the pregnancy fairly quickly. I mean, I get very stressed. I mean, time to pregnancy for me is a very important factor. We cannot have our patients hanging on forever. You know, when I was younger, I was visiting clinics all over the world. I still do, but I don't visit many times. And, you know, in so many times I saw patients 2 years later, still there, same patients. 3 years later, still there. And these are the resilient ones. And all I have to say here is that if you really keep going, you will achieve the pregnancy at the end. But unfortunately, you know, they're not all people made of steel. So people may give up, they may become disheartened. So I would like to offer as much as I have, with a reason, every single time after a failure. So yes, I would consider it.
Right. All right, perfect. Thank you so much. We will be slowly finishing. We won't be able. Yes,
Yeah,
sorry.
sorry to interrupt, Carla. And please remember this. I mentioned it a couple of times, but I need to stress that sometimes the function of the endometrium we cannot see. Not sometimes, many times. So an abnormal endometrium is not just the thin endometrium. You know, the abnormality of the endometrium is not always, invariably, is not visible on scan, even on high resolution scan. So, you know, it's a function that gets seriously improved, in my opinion, with PRP, especially after many failures, rather than the anatomy that can be seen. As seen in the studies, you know, 1 millimeter improvement is very near to nil. Yeah, 1 millimeter on my scanner with my hand could be 0 millimeters on my colleagues' hands in the same scanner. So, you know, it's a function that we're aiming at.
Right. Thank you so much. And there are more comments, and actually, I'm smiling because I've just read that one of the past patients is right here with us as well from with Dr. Tsakos. So thanks a lot for that. And I will actually show you the question from Karen, our previous patient, that she asked the question. So let me just show you. Just give me a second. It's right here, as this is the continuation, let's say. So continue from my past question. I don't have option to PGTA test on current clinic, but due to age and 4 failed attempts, I wasn't sure to bother, as not many embryos, 1, 2 maximum, and also male factor. Though if only a couple attempts left to spend time fixing endometrium rather than testing embryos, which we can fix. Anything you can advise here?
Well, to be honest, Kaina, I'm sorry, but you know, in my opinion, you know, you have a clear indication for PGTA, even if you have 1 or 2 embryos. Implanting an abnormal embryo, the risk of implanting an abnormal embryo, the biggest risk is not failure. the biggest risk is miscarriage, ectopic, or carry on with the pregnancy, which becomes undiagnosed child with some anomaly. These are the biggest risks, in my opinion. Now, if you're 40 and your husband has also male factor, that's an extra. The male factor infertility is also an extra indication for PGTA. There's no, in my opinion, I'm sorry that your clinic doesn't offer that, but I'm sure you can find it somewhere in your area or beyond. I think it's medically, there's a very clear indication for PGTA, and there's no point looking into fixing the soil if you're not sure about the seed. That's my opinion. I hope I have helped. We have a couple of, sorry, Caroline, but I can see some amazing questions, and I'm sorry we
There are
can't.
lots of them.
I would pick out a couple from colleagues. Thank you so much, my dear colleagues. So I would like to address those, if that's okay.
Sure, let's go for it. Sure.
To see you for a hysteroscopy. There's somebody coming to Athens. I'm sorry, but we're in Salonika.
Yes.
It's only 40 minutes flight, but it's Thessaloniki. By
That's
all
true.
means, if you want to visit us, Janet, get in touch. I mean, if you don't mind, Caroline, type. You can send an email, and I'm sure my team can pick it up and help you.
Definitely. And also remember that we are not able to answer all of your questions. There are plenty of those, but we will forward the questions that have not been answered. So we will be able to forward those to Dr. Tsakos, his team. And also if anyone would like to, because there was also ask for the possible collaboration. So I will again be able to.
By all means, dear colleague, I'm more than delighted and would be more than happy. And thank you so much for your interest. Please get in touch, send me an email. We can collaborate. We have amazing projects going on at the moment, more than 10. We would be delighted to share our knowledge and, of course, get your experience as well. And, this is how we grew. We grew through collaboration with patients and doctors. And thank you so much to my colleague, Stelios, who said that he hasn't heard that hysteroscopic management of miscarriage during his residency. Stelios, come and visit us for a couple of days, and I promise you will hear things that you haven't heard before. And I challenge you to challenge us as much as you can, because it's through this challenge that we all get better. So thank you so much for your interaction tonight. And I think there was another question from a colleague. Oh yeah, how can I refer patients to your clinic? From Dr.
That's why.
Thank you so much. I mean, please send Dr. colleagues, send us an email, and we're going to have a little Skype, the two of us first, in order to understand, what kind of collaboration you would wish. I would be more than happy to share our experience, our protocols. We can share our protocol. It's not a secret. I'm just trying to collect all the data for the publication. And I promise to everyone that it would be very clear on the publication. You don't need to refer if you're far away. I would be more than happy if you can visit us for 2 days. 2 days is enough. We will show you our protocol, how we treat our patients. We can share all our data, all our consents, our GDPR, how we inform the patients. With their consent or permission, you can watch how we do it and then take it back home with you. This is not a secret. I think we should be sharing our experience. And thank you so much, Dr. Cordota, for your interest. So please drop me a line and I will be more than happy to take it on from there.
That was great.
And
Dr. Tsakos.
From Uganda, East Africa. That's one of my dreams, to visit your country. I have amazing friends from your country, and some of them are my teachers as well in England. So thank you so much for attending. And please don't hesitate. Each one of you, please feel free to drop me a line. We didn't speak to a French patient here, the 49-year-old.
I will be happy to forward this.
I can read French, but I don't speak very well, but I'm looking forward to exchanging.
Definitely.
I can see here that you would like to know more information about PRP. That's from Luanzo. By all means, drop us a line. Being 49 is not a problem. We can optimize every piece of the puzzle, and I'm sure you can have the best chance in the world.
Definitely.
And thank you Thank you from Dublin. Yeah, nice. Good. Well, I have very good memories from Dublin, and they have very good hospitality.
That's great to hear as well. So, again, thank you so much. I think we will be finishing for today. As you can see, there are plenty of questions, plenty of comments. As I mentioned, I will be happy to forward those to the team and Dr. Tsakos. I'm sure they will be able to get back to you. So, thanks everyone for joining. It's been a great session. And I know we could take 1 hour more and it would not be enough to discuss this. The way we would like, but of course, remember, we will be back with some more events also with Dr. Tsakos in May. We will talk about some other topics with him as well. So go to myivfenses.com website, and I'm sure you will find all kinds of different topics, and we'll be happy to have you and help you out as much as possible. Dr. Tsakos, lovely to have you as always. Yeah, I think that will be it for today, but we will see each other soon. Thanks, everyone, and have
Good
a
night,
lovely evening.
everyone. Bye bye. Thank
Good
you, Carla.
night. Take care. Bye
Thank you.
bye.
Bye bye.